morning, everybody. Here from Switzerland, and good morning, Joel, to Portugal.
Hello,
Hi.
good morning.
Good morning, everybody, to the last session of the triple session with Joel Teles to this webinar. The main topic is immediate placements and immediate loadings. We had the first session on the 1st of April where we started with single restorations and in the molar region in the aesthetic zones where we learned about the main issue about the aesthetics, about the tissue management and so on, which we're going to repeat, or Joel is going to repeat in a second. And then the second session was a big topic, all on TRI situations, all on 4 full arch restorations. And today we got all the questions of you from the last webinars. We got a lot of emails and big feedback. Thank you for these feedbacks from all around the world. And we try to work out this session a lot of questions to answer, and also I think Joel has a lot of tips and tricks included in his presentation today. And but I think that it's not enough to have only this way of presentations, and that's why we want to announce that we had to change the dates of our training and course in Zurich from the 19th of June to the end of the year, to the 26th and 27th of November. It's going to be a great session with Joel, and that we will have a big hands-on session, including for the all-on-4 technology or for full arch techniques, and also there is included to see the production side of TRI. So sign up for this. It's always, since we do these webinars, many people around the world want to have a course with Joel. And also I would like to announce the next webinar session, which we start on the 29th of April. In this case, it is with Dr. Alex Ionescu from Romania. Alex is first of all a tissue level user, and secondly, his most treatment ways are minimal invasive. And now the topic is going to be a very hot topic: digital guided flapless implantology. Main treatment options after the pandemic is maybe a very good way to have a minimal invasive way to treat your patients. So please sign up for this session. And now I would love to give the words to Joel. Joel, I share the screen, and please go ahead with your presentation. And as always, we're going to also give the chance to you to have your questions during this presentation. So write your questions in the question mark field. I will pass them to Joel during this presentation, including the questions from the last webinars. So, 1 second. So now you should get your screen. Okay, looks good.
I just don't get to see ourselves because it happened again. I cannot see my webcam, but I'll try to solve that. Just give me a minute. It's solved. Okay.
Great.
So
please.
First of all, thank you all for listening to us once more. So for those of you that missed the first 2 webinars, this is a Q&A session. So we'll try to highlight some things that we on the questions we got answered afterwards, that we realized that maybe you still have some doubts regarding some parts, and I'll go through it and try to explain and take out most of your doubts. Of course, there were too many questions. We got more than 100 questions. We cannot answer them all, otherwise we'll be here for the full day. And like Olga said, it's not possible even in 3 series of webinars to make you understand everything that is the philosophy of the work that I do. But I'll try to be as clear as possible, and I'll try to give you all the answers that I think are appropriate to the questions that you make. So let's dive into it. So remember, this is not a complete presentation. This is more orientated for the questions that you guys did for us. So you will not have a complete timeline of any kind of treatment. You will have highlighted some scenarios of all these 2 webinars. For the ones that are listening to this and didn't get to see the first 2 ones, you can see them online on YouTube on 3 Dental Implants page and channel. So on this part here, I got a lot of questions about the tools I use for traumatic extractions, and also how to clean the sockets that were contaminated. So the first tip, and that some of you asked, is about how to separate the roots. And I try to do this with keeping the tissue unarmed. And so the way I do it is that I'll go with the drill, I'll do the cuttings in between the roots, and afterwards I will break the last bit. So I won't go to the very end. And that's the small tip I gave you, because if you get to see surgery on YouTube or presentations or whatever, you will see that one very common thing is that these parts of the tissue will get harmed during the extraction. And sometimes it has to do with the drilling separating the roots. So if you are careful enough, you can do that, and in the end have a perfectly clean tissue. Then the next thing is that to separate the tissue, to do that intersuccular incision, we have to use either the 15C blade or a microsurgical blade. It depends on the case. Most of the times a 50C blade is perfectly enough. Sometimes I'll go with a microsurgical blade. And this instrument that a lot of you asked is a Pilux. It's a periotome, and it's again sold by Schwert. And it's very helpful because you really can feel it, that you're separating the root from the bone. So it works very well, and I enjoy using it before I extract the root. And the last thing about, yes?
There was already one question. I don't see the name yet. Who was asking the question about a cleaning of this extracted wound? Do you use antibiotics? How do you do that?
Okay. In the past, I did. I used to use metronidazole, which I would irrigate in the socket. Sometimes I would do a second irrigation with chlorhexidine, but nowadays I don't anymore. I see no difference in results. It's much better to clean physically. So the antibiotics are done in advance, but with pills, systemic. And locally, it's only, of course, they do the mouthwash before the surgery, yes, like in every surgery, but and it's cleaned with betadine. But after the extraction, it's only about cleaning the socket physically. So for that, again, what I use is these carets, these Lucas carets from Schwert again. And I'm not trying to make any time of advertisement for Schwert. They don't pay me whatsoever. It's just the things I use, and I think it's valid for you to understand what I use. So this dented part of the curette, you can see it, that it has some indentations on it. It really helps you to remove everything. You get really a good sense of grip. There's no turning back after you try this, I assure you. Every single person I speak who uses this, once you go back to your old curettes, they don't work all that well. And one thing I see a lot of people was doing, and myself were doing, is that sometimes I would use, I don't know how to say in English, but what we use to remove carried dentin in dentistry, I would use those instead of curettes, because I didn't get the feeling that I was actually removing all that well the contaminated tissue. So with these things here, that really happens. You get a good feeling that what you are taking, you can feel, and so that's what I use. And of course, irrigation with saline water, but that's it. I don't use nothing more. The image on the left is, somebody asked me, what if there is a cyst or something, do you still go with the surgery? The answer is, if the infection is not acute, if I can control the infection and turn it into from an acute infection to a not acute infection, I don't know to say this better, I will continue. So I'll remove, like you see here, I clean everything and I'll go in. Of course, if you're talking about the molar site, I will try to avoid the region where the cyst was. If we're talking, like in this case, it was a premolar, I went with it anyhow. Okay.
Okay,
Yes.
let me ask you one question from Nessie Ayrton. When do you clean from after drill? When do you clean? Sorry, when do you clean from after drill? I mean, I think it's a question if you drill first, but I think it's just the extraction
No.
and then you clean.
Exactly.
I hope that answers your question.
Exactly. Okay. There are some situations that actually is a good question. There are some situations, but not on these particular cases. More in full arch approaches, where I'll be doing the drilling, and after I went for I passed my pilot drill with a small curette, I'll go inside and clean some things, because I get to see, or on the CBCT, or I get the feeling. It's all about tactile experience as well. So when I'm doing the drilling, if I kind of sense something in between my drilling procedure, sometimes I go with the drill, and sometimes what you can find is things that were left many years ago when the extractions were done. So sometimes I will go on the sock that I'm creating with these curettes and cleaning inside. Yes, I do that sometimes, but not particularly in this scenario. So here you got the curettes that we are discussing about. Okay, this we got asked a lot about what material was used to create these individualized inlaying abutments, and it's flow composites. That's it. Normally, due to the consistency of it, what I do is that I pick up the abutment, the provisional abutment, either PEEK or titanium in molar region. If it is a static zone, it will be PEEK always. I'll screw it in place, and I will start with big pieces of composite, normal composite, and I'll do the first thing. So I will try to recreate all of these touching directly before the grafts. I will try to recreate this with big pieces of composite, and afterwards with flow I'll fill up the rest. So once I take it out, it's more or less this rough shape that you can see here, and afterwards I'll just have to reshape here, and all this inner part needs to be very well polished to be better for tissue healing. But it's a very easy and simple and quick process. It's nothing too complicated. It's done directly on the site of the surgery. There's no problem whatsoever to do it like this. Okay. So the next.
There was one more question. We got it from last time. You can see here the immediate placed implants, and then you filled up with some bone materials. And there's the question: don't you use a membrane for these cases?
No. The answer is no. In this scenario, you don't need membrane. The sealing of the socket is done with a healing abutment alone, nothing more. And also, I don't use stitches in this scenario. If the tissue is unarmed, I will not use tissues. I will not use sutures. It's left exactly like this, and it's the healing abutment that is sealing the socket and keeping the tissues in place. So, and this is very, very easy, very, very predictable, with really good results. The thing is that you need primer stability to do it, so it depends a lot on the way you extract your tooth and the conditions itself on the fresh socket, and of course again on the amount of bone. That was a question for somebody, I don't remember now, that asked in premolar site, because he said it's difficult in premolar site to get the proper primal stability, and therefore you would place the implant more on the palatal side, trying to get grip on that wall. I'm sorry, I don't remember who asked this question, but somebody was very specific about this. Yeah, it's exactly how I do it. So if I have sufficient height, meaning if it's more likely in fourth than in fifth, but if I have sufficient height, I will just get that primal stability up from the root positioning. If I don't have that space, that amount of bone apically to the root to encourage my implant, then I will do it exactly like you said, using the palatal wall to get that same primal stability. So you are perfectly correct. I do exactly the same thing. Even though I prefer to put my implant, like I told you in premolars, exactly in the middle of the socket. It has to do with the force and with the long-term results for those implants. Okay, so there was some questions about this as well. So I highly recommend you that you go and check out this article from José Carlos Rosa. And it has to do again with this allowing space for tissue and allowing space for grafting in between the socket and your implant. So he has this article about how to choose the right diameter for your implant. This is only from canine to canine. Okay, this is a static zone. What is talking about, but it is for me still the best way to choose the right diameter for your implant. So it's an article that I put here again so that you can go take a look at it, because I think it's very important for your results. It helps you to understand, and you can see that if you look to your older cases when you may not get this right, that it influences the volume that you may end up losing or not. Also, the restoration is very important, as you are going to see. So, like a resume of what we're discussing in the shape of 1, 2, 3, 4, this is normally what I do. So you extract your tooth, trying to keep everything in place, trying not to harm the tissue. And you can see number 2 here, the orientation from my implant. Remember, the right prosthetic position for your implant, if you consider the perfect crown positioning, is touching the palatal side of the socket and not following the root, because remember that kind classification, normally the roots have their they are much more for the buccal side of the bone. And you in number 3 you can see that clearly. You can see right there on the bottom where your root was, and you can see the new alveolum that we've created for our implant. And in number 4 you get to see that space we left in order to be able to graft and to maintain all that information for what we want to keep everything in place, so that we get the sealing of the tissue and we got the bone stability in order not to lose any type of volume there. Okay, so a lot of questions about this, the drilling procedure on these cases. And this is a technique that's called double trajectory technique, and it's very easy to do. First of all, you will start more or less at 45 degrees, aiming for the palatal portion of your socket. So this is buccal, this is palatal, and you go like 45 degrees and more or less 2 to 3 millimeters below the top of the bone. You'll puncture it for about 1 to 2 millimeters, and then you'll start correcting the orientation. So you go like this, and then you'll start correcting like this. You do this with your lens drill and with your pilot drill. Afterwards, you can go directly because you already created the path. But for these 2 drills, it's very important to do it exactly like this. Your hand needs to be, the only tip is this, that your hand needs to be steady, because once you try to puncture that palatal side of the socket, it tends to push you the other way around. So puncture it perfectly. That's why the 45 degrees is helpful. So you puncture it and then start to reshape. This is the puncture that you see here on the image on the background, and it shows the purpose to showing you that's what you create, and then you change in order for the implant to be in the right positioning. It has to do with this. If the restoration is in the ideal position, this is the ideal position for the implant itself, okay? And in this cut of the CVCT, you get to see that this was the original part where the root was. Remember the kind classification, and this is where your implant is. Also, we got some questions regarding that how to level our implant, right? A bunch of questions about this. Well, it depends on a lot of things. It depends on the implant you're using. It depends on the tissue, the height of the tissue that you have. It depends if the tissue is in the correct positioning or not, because remember what I told you about, that you can play a little game with biology if the defect is not that big. If it is, okay, maybe you should do, because I saw that as well. If you don't have keratinized tissue, well, if you don't, there's no way for doing just one surgery in the static zone, because it means that you have a big deficiency of the tissue. But all these considerations need to be taken in place. The quicker answer that everybody will give you is at 3 millimeters below the tissue line. Well, it's not always like this. It depends on many factors. Sometimes I'll go a little bit deeper, and sometimes I'll go like 2 millimeters, 1.5. And it has to do exactly what I want, what my aiming with the tissue is. Okay, up to a certain point. Again, up to a certain point. The border for me is approximately 2 millimeters. So if the defect is more than that, I will not risk it. But if it is in between 1 and something millimeters, I will try to reset biology to work in my favor. I will do my try. In these scenarios, I always try to be as minimally invasive as I can. Always when I'm dealing with a static zone, I try to be as polite with tissue as I can, as polite with biology as I can, because once you start to moving too many things, you add up risk factors, and the answer normally is that you end up losing papilla, losing volume. So I try to give all the right informations for tissue and bone, but and mainly for tissue, but in the most minimally invasive way that I can. Okay, some questions about this as well. A lot of questions about this actually. So this is the shell technique. I create the shell using or the extracted tooth, or I made one directly or before in advance with some casts. The important is that I have a shell, and afterwards
we can say in this moment there is for example from 3M, they produce these shells, plastic shells, PMMA plastic shells,
exactly.
in different sizes and different lengths, and you can buy them prefabricated and individualize them. And what Joel is showing now with this shell technique, either with the extracted tooth or with a plastic shell or with a as you will show, this is doesn't matter. The technique will be the same to stick it onto
exactly.
our TRI temporary peak abutment. So
exactly, that's exactly the point. The way you get the shelf makes no difference, but all of us are trained to do restorations, all of us. So just think in a restorative perspective at first. What would you do if you have to make a direct reconstruction of the root that was there? That's the same line of thought. Only afterwards you'll get the shelf. There are some people that prefer to make a hole in the middle of that crown that can be made, but I prefer to do it like this, create a shelf. It allows for more movement and to feel it that you're placed in the right positioning. And one other small tip is this jig here that I showed you in the first webinar. It's very easy to do once you're dealing with a tooth that needs to be extracted but is still there. and it allows you to always go back to the same positioning. It's as simple as this. So it's a very useful tip that takes you 2 minutes to do this and no money whatsoever. It's just a small amount of composite. So afterwards, you place your shell in the right positioning, and you end up add composite sealing the socket on the posterior region, exactly like you do when you're creating an individualized healing abutment. It's the same principle, exactly the same principle. So once you remove it, this is what you get normally. And you will get to that line in a little bit, but this is what you get. So what you need to do is clean this very well and add flow composite, so you'll reshape this into provisional restoration, like you see on the right. So keep in mind this, go and check out this article. What I discussed with you on the first webinar has to do with this, has to do with these notions, these two lines and this area. And you need to understand where your tissue lies, where's the information for your tissue to be, why is important to reshape this subcritical area to allow space for tissue. What can you do if you need to change something over time? Because normally I'll do the perfect shape before and I will recheck after more or less 2 months or 3 months, and I will see if there is something I think I can still play with biology, meaning adding some space for tissue to come down, or making some concavity, trying to push papilla to coming down. There's some things you can learn how to alter how to reshape your provisionals over time and the responses you get for tissue. The only thing I would tell you is that at first, do everything you can to keep it in the right spot if it is in the right spot. And those changes that you do in time, I would let first the tissue mature enough. I would not try to make that many changes at the beginning. I'll let the tissue mature, and then I'll give some different informations on my provisional, trying to get the responses for tissue that I want. So again, 1, 2, 3, 4 from the same case, and you can see that the volume, the shape of the socket is maintained using this very easy and simple technique. This is nothing new. This is many years of literature behind it. Just to understand all these small concepts that will help you trying to work with biology and trying to make it work on your favor. That's it. That I try to normally I'll play a little bit with this, and I'll say this is always because I'm lazy. I don't want to do too many things. And so if you do this step by step very carefully, normally the responses you get for tissue are amazing. Okay, and the results normally are very, very good. You get to keep volume, get to keep papilla, and it's really, after one surgery you're ready for final restoration. So what's better? Okay, somebody asked a very interesting question about this. The question was, okay, so why not to scan the when you're doing the communication with the lab, why not to scan our provisional restoration, and of course do the mouse scan as well, in order to ask the lab to do the final restoration with the correct shape, exactly the same one that we have on our provisional restoration, in order to keep everything in place. And is, of course, is a very valid way of doing it. Of course it is. I only bring this here to you because not everybody is using intraoral scanners at this moment. I am still, as Olga knows very well, I am still a little bit, I wouldn't say skeptical about it, but the technology for me is not quite there yet. So they are very valid. In these situations, it would be very valid. But till this moment, I still do impressions, and afterwards I enter in the virtual world. So the virtual world for me begins after this point, or this is an interregnum more. because it starts with the CBCT scan and planning virtually the surgery, like I showed you in the last webinars, and then the surgery itself and the impression taking. For me, it's still an analogic procedure, and afterwards with the bench scans, the bench scanner, it enters the virtual world again, and all the restorative procedures are done and checked in a virtual environment. But it's valid for this. It's a very easy and good way to do it, so you could do it like that. Now, this manner that I showed you here, and it's been on the literature for so many years, it's a very easy way to do it, and with very good results, and it's applicable for everybody, if you have or if you have the neural scanner. That's the main advantage. That's why I brought it here. Yes, Olga, you were meaning to ask something.
Yes, we are still on the single side, and so I want to pass this question from Dirk, our friend from Spain. Hi, Dirk.
Hello,
He
Dirk.
asked the case you just showed, that it was clear to see that it is an bruxism patient, and he is asking, what is your approach? Placing a night guard or gaining high with composite, lifting the occlusion? To this, just to the case before and after.
That case that you saw, I think is the case where I showed the shell. Yeah, it's a very actually that patient is father of a colleague of ours, and I didn't know her. She called me and asked if I would do the surgery on her father. I accepted it. The gentleman is a gentleman from 70-something-year-old, and he was missing all his posterior teeth. So if you look on the image, you see that those are implants, and this one was the last one, because I told him it was a very big infection on that tooth, and I told our colleague that she should try to treat that very big infection first, otherwise it would be too risky. So I did the posterior implant at first, and after a few months I did that immediate implant on the aesthetic zone. So you see all of that, all of those teeth are very, very aware of, but because he didn't have posterior support, but now he has. Okay, but imagine the same situation, and it's only to do with bruxism and the loss of guides. Just remove it from occlusion. But of course, in those situations, you should try to convince your patient to solve the big problem and not the smaller one. But sometimes we don't get to do everything we want with patients, and so just remove it from occlusion and then follow the work.
Okay,
if it's
one
not
last
touching.
question to not run out of time from Patami. I don't see the whole name, sorry. For all maxilla tooth, the implant should be placed palatinally. So in a whole maxilla, it's a question to place in the immediate placement maxilla.
If she's talking static zone, yes. If she's talking non-static zone, for me, not.
Yeah. Okay.
In molar sites, I try to go in the middle, and in premolar site the same things with some variations, just with as we discussed. So this is very easy to do. I see some people still didn't understand perfectly, but it's very easy. You pick up a copy analog for your implant, you screw your provisional restoration in place, you put it in silicone, and you wait. Once it gets hard, you remove the provisional restoration, and you get what you see here in the middle. So afterwards, you pick up an impression copy, screw it in place, and with flow composite, fill the gap. Lightening, wait, remove, and you have this on the bottom. So with this, which is an individualized impression copying, with the exact same shape of your provisional, you go into the socket to make to your implant to make the impression. So it's very easy to do, very simple. After this, there was a bunch of questions about communication with the lab. The first thing, and most important, it goes for everything, is that communication with the lab is not a single event. So I really need a team prepared. So my lab knows very well my pictures. They know the exact camera I use. They know the flash I use, And after, because every camera has identity, there's different regarding colors. There are different approaches with different cameras, with different setups. So it's very, and then you got the monitor of your computer also has different approach on color. So this takes a while to be completely synchronized in between the lab and you. But after you pass this point, it's very easy to do. So normally nowadays I would only take pictures with this. This is the ceramic that my lab is using. Even the height of the ceramic needs to be discussed with the lab because it's very important. And this is dentin. This is for dentin. So for the enamel, I have a different scale of blues and grays and stuff in order for it to be able to do the opacities, the transparencies, everything to try to mimic these teeth. So it's a process that takes you a while to be able to have a team completely with the same mindset to do, but after it's very easy and it takes you almost no time. Okay. So make good macro photography for your cases, especially in the static zone.
I think it's also here to repeat just that it is absolutely important that you have built a team between your dental technician and the dentist to be really knowing if the color is explained by the dentist like this, the dental technician knows exactly what it means, and those plates, the color plates, the individualized plates from the dental technician helps you a lot to speak about the same color and
exactly.
not
Exactly.
different.
Everything is important in communication, but with the lab, like I told you, this team thing with technicians is we tend to see our perspective. We tend to see bone, implants, tissue, and that's it. But we forget it's all correlated. What people want, our patient want, is teeth. They don't want to care about bone or implants, or they want teeth. So this communication with the lab is vital for your results, mainly your long-term results. So for me, this is perfectly clear. So afterwards, you go through this, and one thing I thought about afterwards the presentation, the frame of zirconia needs to be individualized. Okay, so all and up until the contact point, it's all the full frame of zirconia, and that goes till that point. The ceramic only is applied when it needs to be applied for aesthetic reasons. Okay. So the frame of zirconia is something individualized for each case. It's not just a normal frame for that you go and you use ceramic all around. No, it's individualized for each case until the contact point. So only zirconia go till the contact point, and in the palatal side, zirconia goes above the tissue, some portion, because it's easier to clean. It's more biocompatible than ceramic. So put ceramic where it absolutely needs to be. So to create things like this. This had to do with another question, the height of the tie bases. It depends on a lot of stuff. If in doubt, go with the 2 millimeters if you can, but it depends a lot on the width of your implant. If your implant is wide, you can use shorter ones like this. And if your tissue is thick, so it has a lot of things going on that you need to consider. But if you're talking about narrower implants and tissue that are more thin, you should go with higher tie bases. Otherwise, you'll compromise your bone stability. It will come down. And then again, the 1, 2, 3, 4 with the same case with the volume from beginning on, exactly in the same positioning. The tissue is exactly in the same positioning from the beginning to the ending of the case. So some key points about this. Remember, primal stability. So you have to have sufficient basal bone left. All the traumatic extraction we just discussed and the contamination of the socket. Remember those corrects. Remember José Carlos Martins da Rosa, correct implant diameter choice. Tissue management, go and read that article. and that individualized impression copying and lab communication. Build up a good team with your lab. It's vital for the success of your restorations. It's vital for the success of your treatments, not only in an aesthetic way. Don't get it wrong. It has absolutely all to do with tissue management. Keep what you achieved. That's very important that you understand that restoration is a big part, is the end of the treatment, but also is what can lead to most periimplantitis are due to restorations. So think about this. And then, of course, final restoration, T-base and true zirconia. Remember the concept for zero bone loss concept.
Okay, before we go into the full arch, we already have 40 minutes done. It's just a question from Sergei Domi. He was asking about the detailed explanation of this temporary creating. And it's always possible to watch these webinars, which we are doing on our YouTube channel from TRI. Plus, everybody who is listening to this webinar gets a link to the videos, recordings from this webinar, and then you can find the past webinars as well. So if you missed anything, just watch the video afterwards. And now continuing with the full arch restorations, and for just to tell you, at the end of this presentation, Joel is going to have a last case where we're going to involve you how you would treat this case, and so I think this part is going to be very interesting now. So
okay, so yeah, for that question that this colleague did, yeah, you have to check the first webinar because it will be too long trying to explain that now, but go check that out. So remember the treatment timeline. Remember that when you're talking about full arch, it's always a prosthetical orientated treatment. The prostheses need to be on your head at the beginning so that you will not mess things up afterwards. Remember that all the surgery is planned considering where you want your teeth to be. It's always, absolutely always like this. Don't go looking at bone, trying to understand what's the right approach with this bone, because in some situations you'll end up cutting a lot of bone in order to be able to put the teeth in their right positioning. People don't pay you for bone, they pay you for teeth that look good, that don't get transition lines exposed. Consider this is a prosthetical treatment. Again, it's always about prosthesis. So, and again, teamwork. These full arch approaches, even more, your technician needs to be involved with them, and from the beginning to the handing, okay? Because this is immediate loadings. You need to have your technician with you. I always have mine with me on the surgical room. So first of all, make your provisionals. That's what leads you to understand where you need to create your shelf, and if it means bone reduction or not, and how much bone reduction does it mean, so you can transfer that to the virtual world when you're planning your surgery on the CBCT, thinking that you need prothetical space. You need these transition lines to be hidden, okay? So there are several ways to transpose this. I already discussed this, but always keep this in mind, because I still saw people asking, why should we reduce bone? A lot of questions about this. A lot of questions about this, about those two incisions there, those cross incisions on the bottom, and why were they important? It's very important, especially in really resolved jaws, because you start the flap handling from those region here, and you go forward, and the same here. If you don't do it like this and you start somewhere here, some of the times in the concavity that happens in really resolved bone, you'll end up puncturing your tissue or damaging it. So you'll end up with not so proper healing. And here the cross has to do with blood supply, and so that you don't get necrosis on that part. Okay. So it's a very small tip, very important in resolved jaws. Again, about this, the flap handling. Always do these sutures on the palatal side to keep it out of the way. And with gauze, you impregnate it with saline water and you put it on the buccal flap, removing it. So if you do this, you'll end up with a clean view of your work field, and you have your both ends free. Okay, this is for me very important. So you don't have too much on your mind doing this surgery. Okay. Now regarding osteotomy, question that bunch of people asked. Why is this line there so visible? Because I tend to place this line a little bit above what I actually need to cut in order not to lose track of space. Once you're doing the surgery, it's easy for you to start cutting, and you destroy the line, and afterwards you get no sense of 3D positioning. So if you're cutting a little bit below the line, it's always present for you, and you can always follow it very parallel to that line. The other thing is, you do it like you see here. It's not flat, it's a little bit like this. For prosthetic positioning, it's way better. For the prosthesis design, is way better. For lip support, is way better. Okay. And I've created this after the presentations because people were asking me a bunch of questions about this. This is my thoughts about why we should create a shelf. Okay. Because for me, it's mandatory in All-on-4 that you create a shelf. You may lead with some cases that they don't need shelf creating, but there are only a few of them like this. The great majority, you have to create a shelf. So for allowing for prosthetic space, remember, more or less 15 millimeters. It's not a strict number for 12 to 18. Remember to idle that transition line. To establish a flat design base for your prosthesis, you need to be flat on the surface as well, on the tissue as well. So normally tissues are completely, you have one part is lower than the other, and that leads to concavities on your prosthesis. That's exactly what you don't want. So create a shelf, a base flat surface for your prosthesis design. It helps you with the width because it grows wider once you start cutting, and very important, it approximates you for the points that you get anchorage, because people were always asking about primal stability. Of course, you need to think about the corticals, and you need to think about the pyramid process right besides the nasal cavity, distally to the nasal cavity. This is the concerns that you need to understand, and this is why this shelf creating is so important. Okay, so I made this slide specifically for this because I saw a lot of people still didn't understanding quite well why the shelf was so important. It's mandatory, okay, in this type of procedure, of course. Now comes to implant placement. It was, yes.
1 second, because there's Tina Saar again, and we had from her a question, and I think we were going to answer it maybe even later, but she's here again and asking again about the, please explain the D vitamin part again. And I think the vitamin D, there was this misunderstanding last time.
Yeah,
I think
yeah.
you can maybe
She's the one that sent that email. You misunderstand what I said, because I said exactly what you were asking on the email. Vitamin D, if it is insufficient, you need supplements. So the levels of vitamin D should not be insufficient, because bone will not heal properly if they are. What I said in the webinar, and if you go and review it, because after I checked their email, I said, did I said the other way around? And I went to the webinar, and I didn't. I said it in the right way. It was a miscommunication, because of what I explained is that sometimes if you look at your patient analysis, and some of them have fresh analysis with them for other stuff, and you can look at the parathormone level, and if it is high, it may lead you to suspect that vitamin D will be low. Okay, and sometimes this is a good reference that you have, because normal people have that do regular exams every 6 months. Some of the doctors will ask for parathormone levels, but not vitamin D levels. And this is a way you can correlate these two things together and understand that you should be careful with that. That's what I said. Okay. Regarding this, people were asking me a lot about in D4 bone like this, what are the tips and tricks to get anchorage? Remember, if you did this shelf properly, you are now closer to the anchorage points, and there are the ones that will allow you for primal stability. And then, of course, there are very small little tips, but I cannot tell you everything. Otherwise, you will not come to our courses. But you have, of course, subfrages. Subfrages is a thing you need to sub-drill in order to get stability. But also there are some tricks that you can use handling this D4 bone that are quite useful when you're dealing with full arch. You need higher torques. You need high torques. This is just a correlation. And Santiago did ask about how do you know the angulation for the implant if it was just by sight. Well, for me now it is, because I've been doing this for so many years that I don't use no type of guide. But in the beginning, and I guess this will be very useful for who's starting, this guide here is very simple to use. There's no fancy stuff. It's very simple. Like I told you in the webinar, it moves a little bit around, and there are some with inclination guides from 30 to 45 degrees. Those are easy to buy, and it can be useful for who's starting all-on-4 treatment. So buy one of those with the angulations as well. This one doesn't have it. It's the image that I pick up online to answer your question, but pick up one of those and you'll be more comfortable. After a while, you'll see what I mean. You end up not using it because once you're starting your planning, you're already drawing in your bone where you need your implants to be, and it's easy for you to understand the inclination that you need. A lot of questions about this. I always try. Yes.
Before we go into the immediate prosthetic creation, because it's one topic itself, there was the question of Nessie Ayrton, why do we cut a lot of bone, which is a part, I think, of the all-on-4 technique, and maybe you can just quickly, because the time is running.
Yeah, I don't like to cut bone. Nobody likes to cut bone. It's only about those things that I just explained. You need to think prosthetically. So if the restoration tells you that you need to cut bone, you have to. That's one of the main mistakes. If you ask me about all-on-4, what's the main mistake? It's not about positioning the implants normally. It's about not understanding the restorative space that is taken in order to keep everything in place. So tell your patient, smile as high as you can. Really move your lip up as high as you can. And that is the image that you should capture, because that's the one who will tell you how much bone you need to cut in order to eye those transition lines and still have restorative space enough in order to get good, cleanable, and resistant restorations. And you need to think about this. If you don't, you'll end up covering mistakes with mistakes. This is something that I go fully in detail in our courses, because this is, like I told you, the main thing I still see people failing. They're afraid of cutting bone. Remember, bone is no patrimony. People are obsessed with bone. As dentists are obsessed with bone. I much prefer to have some cases with fewer bone than with tons of bone that needs to go away, because sometimes it actually needs to go away.
Okay.
Okay. So this, I always try to do these provisional restorations in advance. And I do them. This is a trick that I saw people missed quite a lot, with this transparent acrylic on the palatal. Remember, the easier way to understand if you're doing everything right, if you transpose everything right to the CBCT, is at the beginning of the surgery, after removing the buccal flap. I always go buccal flap first, and before detaching the palatal flap, pick up this. This is a very big denture. It goes all the way to the tuberosities, all the way to the nasal spine here, and all the palatal is touching. So you can fit it in, and there's no doubt where its position is. So you put it in before you start the surgery, and you measure your prothetical space. You know where the smile line of your patient is, and you draw the line there. And then that's it. There you know where your shelf needs to be created before, even during the surgery, with this prepared, because okay, you know this process very well at this moment.
One last question regarding the surgical part from Merdat. I think it's a very good question. How do you avoid nasopalatinal artery? Sometimes if you nick it, starts splashing blood everywhere. How
Yes.
do you?
It happened to me. Yeah, it does not happen to me in very, very long time. Normally, I'll go around it. You can feel it, the depression on the palatal side where it is, and I'll go on the posterior region trying to aim closely to it, and on anterior again. And so I'll leave that small space to be, and I'll detach the tissue as dramatically with gauze with saline water on that region, in order to try to expose the part. But yeah, in the past I've armed it and it bled, and I make some pressure on it with articaine anesthetic as well, and after a while it stopped. But yeah, it's kind of stressful once you did, and all of a sudden your mouth is full with blood. Yeah, I've been there, and sometimes big squirts of blood came out of the patient mouth. But if you're careful enough nowadays, for many years I don't touch, no, even with very big flaps. Go around it,
Last
be
question
safe.
also from Merdat. What is the best burr to create shelf?
Good question. I forgot about that. I had a slide only for that, but I forgot. I use prosthetical burrs with black colors. The prosthetic for the casts. Those are the ones that I use. For me, they are the best. I have torpedo drills, but they are kind of a mess. With big marketing behind them, I prefer prosthetical burrs. That's my answer.
Okay, let's go into the prosthetic part.
Okay, so this is the tie base, the TTAs that you have, and they work for this provisional part, and in the end, again, like tie bases. So always in this part, my technician does the work. So he knows exactly all the principles that we've discussed over the years, and he knows exactly how to transform these prostheses in a fixed provisional restoration. So we will reshape everything, he will cover everything, and end up with these results that you can see that it's very easy to floss here. There's no concavity, it's all very convex, it's very easy to clean, and it has to be exactly like this. If not, you'll be damaging your healing. And see about prosthetical space that we've discussed. If not creating a shelf here, normally will not get this high, and therefore you will have in problems. Some people ask me, don't you have breaking on your provisionals? Nowadays, very, very, very small amount of times. And why? Due to thinking about space you need. If it's restorations like this, think about 15 millimeters. Sometimes the patient is very big, very strong, even higher, 18 millimeters. Keep this all in mind. Otherwise, they will be too fragile, and of course, they will break. See the bottom of the restoration, very cleanable, no concavities whatsoever, and the pieces of metal exposed. This is very important for tissue have space to lie. Sutures. People asked me because they didn't understand quite so well what I did here. So two things first. This the intention is that you get it stress-free of this keratinized tissue here, especially in lower jaw. So the keratinized tissue is very a small amount normally in lower jaw. You put it around your multi-units, and you want it to stay there. If the muscles are doing pressure over there, it will come down, and you'll end up grafting to try to regain keratinized tissue. So think in advance. Go sushi technique, separate it very carefully, put it on place, and sometimes giving that cut in the midline is important that you can hold it against the multi-units. And this cut here to release tension from the tongue is also important sometimes. Other times I even release some finance here. And one thing, sometimes I'll go and detach full thickness flap till the keratinized tissue level, and then partial thickness flap, and then remove it all. So I'll end up with stress-free flaps afterwards in the end of the suture. And the suture 5-0 always resorbable suture and monofilament.
One thing to add, for the suturing part, you will screw the healing caps on top of the multi-unit abutments during the suture part, and then you remove it to create your prosthesis.
Yes. Yes. Sometimes I'll go a step further and I'll do both things in the same time. So I will place immediately the TTAs. I will suture with the TTAs, and at the same time, while I'm suturing, I'm checking the prosthesis, marking where I want it to be cut, the holes. The technician go and will be opening the holes while I keep suturing. You come back again, I'll see if it's free enough. If not, I'll mark the parts and we'll do this simultaneously, okay, to save time. Oh, one thing about this, you see here, because people were asking, if you look closely to this image, you will see that you can see the teeth here, okay? So you can see that the prosthesis hands here and the prosthesis hands here. So normally I will cut in the, I will not leave cantilevers on provisionals, okay? I avoid totally cantilevers on provisionals. And you can see the beautiful symmetry. About all on 4, this space in between the head of your implants, for me, is key for success. I really do not like too much close-up implants in against each other. Again, about this, a lot of questions about this. This serves for no purpose whatsoever afterwards, except for trying passivity. This is the point for me, especially if I'm dealing with monolithics, where I need to be absolutely sure that everything is passive. And the only way I can be sure enough is if I do this. This is a milled aluminum bar that don't flex all that much. It's very stiff, and I can show, I can see, and I can transmit to my lab perfectly with good X-rays individualized in each implant if it is perfectly passive. For here on, it cannot be no doubt in my head and in the lab's head, that in the technician's head, that this is absolutely passive. So our virtual model, our actual model, and our patient mouth are the same. Okay. Okay, so trying. Olga, you want to answer that question that we got a lot, yeah?
Yes, I just try to translate a few questions from Saudi Arabia. Hi, to Mr. Dr. Salman. He is asking about how much cantilever do you add in the back in palatinal? How long, how much cantilever you would recommend in all on 4?
Yeah, in lower jaw, sometimes it will happen that you will have 2 teeth cantilever, the 5th and the 6th. It will happen. Yeah.
Another question.
More than that, it's almost never.
Another question from Dirk from Spain. Do you use Ostel or Penguin to measure your bone
No,
stability?
No, I've used in the past. Nowadays, I'll just go with torque and the.
It's a question of feeling, and I think it's also about the TRI implant design, which gives you, and I think Dirk, you know exactly that you reach this primer stability.
Very
maybe
well.
another time, because that question we had answer, how high will be your primer stability to load directly?
Higher than 32.
32. Okay. So to this step, there was questions about the prosthetic design. How can There was the question, how can you know if you are 30 degrees or 35 or even up to 40 degrees angulated with your distal placed implants? And so if it is too much or too less angulated the implant and you use the 30 degrees angulated abutments, it doesn't matter if it's not really in a horizontal direction, because as you can see here in this molar region placed implants, or the prosthetic part here, it's still angulated, but due to the fact that the design of the abutments have a 15 degrees top part, you can also have a distance between the abutments which are looking out up to 30 degrees. So it is not necessarily important that you have a straight angulation from 30 degrees placed implant. You can vary this depending on the case for sure. And anyway, get in one piece your prosthetic placed and screw retained on the abutments.
That was a very good question because we sometimes place implants in 45 degrees and only can compensate that to 30 degrees. That was a very good question, but you perfectly answered that. So this try-in is where you do everything you need to do regarding your lateral movements, protrusive movements. Remember, if you do dealing with monolithics, after this you don't get to touch nothing. So make sure everything is perfect occlusion-wise in that appointment. And here you got to choose the height of your thigh bases on the virtual library using the drawings of the the trying that you just did. So all the alterations are now virtual again, and you get to choose the correct height in each positioning.
Let me add here two things prosthetic wise. So you see on the left side the height of the TTA abutment, which Joel used for the temporary restoration during the operation, so the immediate restoration. You can use it very long, and then you have these 5 different heights which you can choose also digitally. So in this picture where there's written CAD CAM, and underneath you see the lowest cut, the number 1 cut, which is used as a tie base for multi-unit restorations. And so you can create a monolithic full arch, and then you bond the tie bases underneath your full arch, and that's a great thing. It is a temporary and it's a tie base on top of multi units, our TTA abutment from TRI. And that leads me to the question from Amin. Can you please explain a bit more about the passive fit of the aluminium jig? This is just like if you have a case as Joel here just showing that the full arch, full monolithic restoration. If you create something like this without checking the passive fit of your situation with an aluminium milled construction, as Joel showed, it's a bit risky. And to make very much sure that the situation, the fitting of your final restoration is 100% fitting exactly as on the model for the technician, and Joel is doing an aluminium control check with these aluminium bars. That's the only reason why he's doing
it. Look, the relations with your technicians need to be what I try to say is this: if and in the past it happened to me, if one of these monolithics breaks at one point, whose fault is this? You're going to blame it on the lab, and the lab will blame it on you. So which of the parts did something wrong? Was a criteria for monolithic construction that was not done properly, the cooling time, anything that might happen, or is it something that we did? So I don't touch the monolithics after I place them. Don't do any type of adjusting on the biting and the movements. All is done on the try-ins, and my lab has the X-rays very properly done in the right positioning for all of this positioning of the type of the aluminium bar, so he knows it's absolutely passive without a shadow of a doubt. So if anything goes wrong, and I tell you now that normally nowadays it almost never goes wrong, we get to understand what might have happened and whose fault it is. Okay, so it's a clear situation for everybody. We all make mistakes. So if we document everything and we're sure about every step of the way what we're doing, we'll end up with fewer problems in the future. And with monolithics, I learned the hard way that they are temperamental. Okay, so you need to be really careful with them. They are very stiff, very strong, but also very fragile. And especially if you're dealing like this, what I still do with ceramic cutback with 0.5 millimeters. Okay, so these 0.5 millimeters should not touch in every movement, any movement that your patient does. Only what you see here, only the monolithic structure itself handles the forces. Okay, so it's very, very important. And in the posterior region, sometimes the tooth are live like this, only monolithics, no ceramic veneering whatsoever. The ceramic veneer is only for the smile aesthetic zone, and that's it. Okay, this is the positioning where your tie bases or your TTAs will be cemented afterwards. And so you get these, like I told you, beautiful pieces of art. And you get your final X-ray, you get to see your milled titanium bar and your monolithics on the upper jaw, and you can see the absolute bone stability of a case like this. And you got to see the final restoration for this gentleman that I showed you, with perfect integration in between teeth and his the rest of his face. And now I would like to end this up. The more interactive we can. We spend much more time than we thought, Holger, with this. Yeah, but okay, we try to be as clear as possible for you and for your questions. We did spend much time reading them and trying to understand the best way to give you the right answers. We actually wanted you to understand everything and not leaving nothing to be said. I would like to finish with this case that I didn't show you yet, and ask you the questions, because the idea was that I came with this case for you, and you can get back to me. What would you do now that you saw these two webinars? Yes, Olga.
Okay. So before we started, just to explain again, this is a case which Joel treated, and we would like to ask you in this situation. Joel will explain the situation of this case, and we would like to ask you what would you do in this case, and then Joel is going to show at the end how he treated this case. But before we go into that, we have several questions, but please try to make your answers a bit shorter. The Kaudar from Tunisia, she asked, will you load immediate if only one anterior straight implant is torqued above 20 Newton centimeters, or because there's several implants with less and low. So just maybe a quick question to this.
Yeah, it depends on a lot of stuff. It's difficult for me to have an implant with only 20 Newton meters. With your implants, it's very tough to imagine that for me. Normally, I would always get higher than that. If I didn't, I would have add some tips and tricks to gain torque. But in the worst case scenario, I cannot get more than 20. I have the other three with torque. I would load that implant as well. The main risk I'm taking is that it will not integrate. If it will not integrate, I will have the other three integrated then, and my treatment timeline will be bigger because I will have to place another one in that scenario. What I do sometimes, if something happens, is that I immediately place, if I can, another implant that will stay there and that will be used afterwards. But I placed it anyhow at that moment, so I can charge that one afterwards. So this is something that I do, not that much, but sometimes I do. Okay, and sometimes I'll end up with all the 5 of them integrated, and I'll continue with the 5.
Okay, Kauda should answer your question so far. Greetings to Tunisia from this side.
Greetings,
then there's, I think this is the question to lead to this case from Fahad Rehman. What if bone is uneven even after bone cutting? I mean, an extremely resorbable bone in a spot. So if you can't make it completely evil, and I think this is maybe a good case here, where this, as far as I remember, is the case that you can go on one level. But that's a good question, I think.
Yeah, it is a good question. There are some tricky cases. Actually, if you go and see the webinar, the second webinar we did, the final case was one of those cases. We need to cut in the bottom, and we didn't have that much to cut. There are some bone reduction limits that you should be aware of, but that will only happen in a small amount of your cases. And regarding resorption, it depends on the resorption. If it is a very regarding height, then maybe you only need to do the flattening and that's it. If it's regarding and this in this sense, the tougher cases will be the ones where the sinus is too pneumatized. So maybe you need to do first sinus lift and afterwards bone cutting. It may happen cases like this. They are not very common, but that may happen. Okay.
Okay.
So you need to be careful with this.
I answer quickly the question of Mohamed Edaif from Morocco. Hi, Mohamed. Nice you're in. He's asking about the aluminium fit check. Why not using a stone? I think why not using a full ceramic to check it is his question. And why aluminium? It's just because you can mill aluminium very much faster than any high quality materials. So the milling centers provide this very cheap. It's much cheaper than creating anything out of the zirconia or whatever, even titanium. Because the milling machine is much quicker to mill it, and it's really only to check the fitting, the passive fit of everything before creating the full final restoration. I hope this answers your question. And then one last question: how
Perfect.
do you check integration as the multi-unit abutments are already in place? Maybe that's the last question, and then we go into
I didn't understand the question. The connection is very bad.
The osseointegration as the multi-unit abutments are already in place. I mean,
how do I check the osseointegration?
I think
if they're not osseointegrated then at this moment being in load, because this is actually one of the few cases that actually loaded since day 0. Okay, well, once you're dealing with single crowns, you take it out of occlusion, but in this moment not. They are biting on this since day 0, so you will know if the implant is not osseointegrated in the end. Remember, you will detach all of these and go for final restoration, so there's a bunch of proof that you'll be screwing and then screwing and screwing and then unscrewing, so there's no doubt about this. Okay,
so let's go into this last part of the presentation. And you see this case. Joel is going to explain the case. I try to pass your recommendations for this case to Joel quickly, and then we see how Joel did solve this very tricky case. Continue.
Okay, so this lady was 60. She was wearing dentures for several years now. I guess more or less 30, and you can see that it's very resorbed, a very small lip. Lips are always on my mind when I try to plan this, and a very small lip, so there's not much volume to hide anything behind that lip. And when she smiled in the right image, you can see that this tissue of the patient being when she smiled. So immediately you think about transition lines. So this is the panoramic x-ray for this patient. This is the scenario that we have in mouth, and she wanted fixed teeth on the upper jaw. Okay, I don't know if the video is going to work or not. I'm going to try to show you the CBCT, but the connection is not so good. We had a storm last night here, and the connection of the internet is not that good. But if you can see here, I'll stop the video here so you can see the images. At least if you see on the right side, very, very small ridge, okay, in the premaxillary area, all around. Okay, so the question is, how would you approach this type of scenario? What do you think would be the surgical perspective of approaching a case such as this? Considering what we discussed in the last webinar, what would be the proper or the easier, the most beneficial approach in such case scenario? That is my question.
Okay, I had also the problem to see the video very well and listen to your voice. That was a bit problem, but I think this last slide now it shows where that there's almost none of bone. And as Joel explained, this patient, she wanted to have a screw retained situation in their mouth. And the question is, how would you treat this case? What would you do first? How would you do that? I'm waiting for some ideas of you. Please give me your ideas. Oh, the first one is just popping in. What about bone regeneration? What this is a question from the US, from Graham from the USA. So, hi.
Hello, Graham. I met Graham once. Hello, in Pios da Régua. Okay, so most of us would go for bone grafting. Of course, it is a way that the approach. But remember, the patient is 60. He didn't lose his teeth for nothing, so there's an history there. We get to see that immediately when she smiles, you saw tissue on the posterior regions, because the resorption pattern is like this. It's very common with when people are using dentures for many years, and the lip is very small. So in this case scenario, and regarding her age, for me it's very clear that I try to use what I have. Once we start entering grafts, we end up with more procedures. The amount of procedures add up. We are dealing with more morbidity. We are dealing with higher costs. We are dealing with high percentage of problems, because the healing on these patients over 60, especially ladies, is compromised in some point. And so you add up problems to solve this case. So for me, it's an option. I would not go that way.
Okay. That was, I think, answering that question. I think it's always a question about time and money of patient with bone regeneration. There is a question from Fahad Rehman. Tuberosity implants. So I think it's sarcoma implants, would be maybe or tuberosity.
There will be an option as well. If he's talking about zygoma, again, higher morbidity, way higher costs, needed for surgical room. That is not always like this, but it is a thing to consider. And the leverage effect on zygoma implants is something that I really do not like all that much. So in long-term results, if I can avoid them, I would. And in this case scenario, yes, there is some other options. So I would not go zygoma.
Okay, and answer that question. We had this zygoma question from Barry Rimmer as well. And Dr. Salman from Saudi Arabia and Sajir Macrophotography are asking about a split crest. What about a split crest to create more?
Good question. Good question. If this was a scenario in which I was dealing with a small bridge in a small portion, I would do split crest, because it's very triangular, that shape, so it's perfect for split crest. But if we're dealing with immediate loading, full arch approaches, there are better ways of approaching these. I would not go split crest, because it might lead to two problems. One, compromise the loading capacity, the immediate loading capacity, and two, if even if it has torque enough and you go for immediate loading, the portion that you just split may end up breaking due to pressure, because this is an immediate loading, and you have to graft. So too many problems for me in full arch approaches once dealing with immediate loading if I go for split crest. So I would not go there. Okay, we're short on time, so if there's no other option, I will.
But that doesn't matter. I hope so far we could answer the question from last time, and there came a lot of questions in there. That's why we are a little bit running out of time. But I think everybody is very excited about to see how you solve this case. So continue, please.
Okay. So like I told you last time, and for me this is very important. If in situations such as this you are in doubt, go palatal approach. And this is like I always like to tell this to people: don't be afraid of going palatal approach. This is the right approach for several cases such as this, and it will help you to solve these cases without complications, easy, low costs, treatment lines are very limited in time, immediate loading, immediate function. So it has a lot of advantages. So this is a resort case, and even so, I created the shelf you see here, and I went all the way to the other side. You can see it already looks way better than on this side that's untouched till this moment. So create the shelf anyhow, and go and do this. So for me, this makes all the sense in the world. Imagine if I try to aim my implant on the ridge itself, that is more or less 3 millimeters, I would end up with nothing. I would compromise everything. If I go and place my implant on a palatal with a palatal approach, I'll end up with all of these protecting the forces around my implants. Remember, all the forces are from inside out in the upper jaw. So by doing this, you have all this bone protecting and securing your forces and your tissue on the buccal side. So taking a closer look, this is what you get on the palatal side. You get all these threads exposed, and you do nothing. You trust this thick periosteum of the palatal side. Literature shows you there's no difference if you graft or if you don't graft. So if there is no difference, don't go and say I feel most secure if I graft, because that means nothing. What we should do, and for me this is perfectly clear, is follow what it's described as being the best way. And the best way in this scenario is the simpler way. Do nothing, trust your periosteum, and hold it against the threads of your implant. So I went for provisional restoration. This is the provisional restoration, and this is the immediate aesthetics. So immediately after surgery, the lady was looking like this after more than 30 years without supported teeth. This is the panoramic X-ray. Yes.
Sorry, I think it's a very good question. Fortius Anesthesis. I think this is from Greece. You may use this approach for single implants as well. The palatinal approach.
No. Yeah, it's a good question. Okay, I will not tell you absolutely not, because I've used it, but it's not something that is described. And normally, remember, in single crown, you need to think about the restoration you're doing and where the screw is coming out on the restoration. Otherwise, you'll end up with a restoration here and your implant here. You understand what I'm saying? And this will not work. So it can be useful trying to avoid some situations with small bridges, and then you do the grafting anyhow, because I will, in those situations, I will graft anyhow to keep everything in place. It will may help you to put it a little bit there, compromising a little bit where the screw is coming off, if you have the feeling that you will find better bone and therefore better long-term solutions. But this is particularly for full arch approaches. Okay. So after 3 months, this is what we get. Look at the tissue, look at tissue stability. This is always like this in a palatal approach. Tissues always are very thick around our multi-unit abutment. Remember, we came from this situation to that situation. And this is the common thing that will happen if you start doing these approaches more palatal than normal in these resort bridges. And this is a perfect example for when you're starting to do palatal approach. This is the perfect case for those, because it's very easy to do. Just think where you're going to place your implant. So okay. This is the final rest. Yes.
Now there's popping a new question. I think we can do another webinar next week because it's really a topic, interesting topic, and for sure a treatment way with palatinal approach, which creates a lot of questions. So let me pass this question from Dalit Kumar. Sorry, I don't know where you're from. So there is no osseointegration on the palatinal side. So will not be there more risk of bacterial contamination and peri-implantitis? Question mark.
Good question. That was, of course, the question at the beginning of these techniques. Remember, this is a 21-year-old technique. This is nothing new. And you have some interesting studies that you should read about. It's written in 2015 by Peñarrocha from Valencia, and it has a study of 5-year timeline results using palatal approach versus using a regular approach, and it shows there are not difference in results regarding periimplantitis. It didn't find any single case of periimplantitis, and the success rates were even so slightly better than in normal approaches, which is kind of mind-blowing. So go and read that article, it's very good. So the answer is no. I don't. The thickness of that palatal mucosa is key for success in these cases. So I don't get periimplantitis in these situations. Okay.
There's a question from Dr. Poe. In the beautiful country where we normally would do a course just a few weeks ago. And hello, Dr. Poe. Is there any benefits for grafting from palatal implant exposed compared with no graftings?
No, there is none. That's why we don't graft no more. This technique shows no. The article shows no difference in results. And the thing is, if you go into graft that stuff, you need to understand two things. First, you're going to graft. Afterwards, you're going to put a membrane there, and afterwards, you're going to place some resorbable sutures above it. And if you listen to what Steigman says, and the things about resorbable membranes and resorbable sutures, they don't go along all that well. So you add up problems, and sometimes you'll add up with worse results because you're adding mistakes with tougher procedures. So in this case scenario, do nothing, leave them exposed. The results will be amazing. And like I told you, you can go and see the last webinar. We showed a really way more difficult case than this one with palatal approach, really big palatal approach. And I have even tougher cases that I show in our courses. And the results, the long-term results are amazing.
Dr. Pope, very much greetings to Cambodia from my side, and Joel and I, we're going to be there and do a big all on TRI course, full arch course as soon as we can. Greetings to Cambodia. I think there is another question. Okay, Dalip is from UK. The question before: Hi Holger, hope you are doing well. Thanks, thanks for the webinar. Okay, this is Dr. Poch. So there's some more questions which I didn't pass all. I'm very sorry for this. Yeah, please show us the final restoration, and then
okay. So this is the final.
From first of all from Joel himself, and also our email address, where you can anyways ask more questions, and we're going to answer these questions also after the webinars.
Okay, so this is the final restoration. In these scenarios, I'll go for acrylic restorations. So this is an hybrid system with metal acrylic restoration. It's better, they're more forgiving, they're more elastic. And so this patient life in 4 months time went from this situation on the left to that situation on the right, in what I found to be a very tricky case with some things that was very difficult to correct. The lip movement was not good. It was very small lip support. We didn't want to end up with no lip support whatsoever and in a really resorb. That's another question that you need to think. That's why making the shelf like this is very important, to add up a little bit of lip support. So all these considerations in a one-step surgery and adding to these results. Now, what I'm about to show you is that this surgery is now 3 years old. And one thing I always do is I control these patients every 6 months, I'm sorry, and I remove the restoration. And as soon as I remove it, I'll take 2 pictures, one from the patient mouth and one for the restoration. And I will show the picture in the end of that appointment. I will show those pictures to the patient. What I found out over the years is that nothing is as powerful as graphic memory. So the first time you show a very unclean prosthesis to your patient, and you let them see it on their hand and on the computer on a big screen filthy, they'll think 2 times before they come to the next appointment like that. You'll make them understand, and it's recorded on your computer what they're doing wrong. Okay, so this is the picture immediately after I remove these próteses, and this is a 3-year follow-up panoramic X-ray, the last one we did, and the picture of that control. So after 3 years, you can get to see the beautifully the bone, how beautiful and stable it is, and you get to see the tissue around your implants. Look how thick it is. Look how the mucosa on the palatal side looks so good, and no grafting was done. And look how the tissue around in the buccal side, of course, is looking amazing, and it's looking amazing because of this technique. And look also about the flat base of your prótese that you get to see there. So just a reminder, these are not new techniques. This palatal approach is from 1999. You can read this article for Torsten Madsen. It's a very good article, the first one ever written about this technique. And you can see here in the actual pictures, look, the amount of implants that were left outside the bone. This is another very useful technique that I recommend you to look at, all-on-4 shelf by Jensen. It's a variation of the regular all-on-4. I use a lot. This is the article I spoke to you before about Peñarrocha and the 5-year results with palatal approach and normal approach, 5-year study. This is from Torsten Madsen, the article I just talked about as well. And so key points just to end this, because you are all tired of listening to me. So first of all, patient selection and orientation are very important. Your patient needs to understand what he's going through, what are the risks. He needs to understand what is or her responsibility about cleaning and about the appointment that he's going to have to come every 6 months, the cost of those appointments as well. He has to know in advance what type of restoration is receiving, what type of procedure is receiving. He needs to understand this in order to everything be perfectly clear before you do anything. The medication, everything. So remember, this is a prosthetically orientated surgery. The planning has to do with the teeth and their positioning, not with the bone. The bone comes second, not first. Remember, osteotomy, the shelf creating, it's mandatory. Very important. When in doubt, go palatal. If you have a 4mm ridge, don't go approaching it on the middle, because I would not use less than 3.7mm implants, and therefore you have only a very small amount of bone on the buccal side supporting your implants and all the forces from the inside out. Place it palatal. Assume 2 or 3 threads exposed and leave this big piece of buccal bone handling the forces. This is a mechanical treatment as well. So think biomechanically as well. Tissue. And this is one other advantage of this palatal approach, tissue management. And in lower jaw, remember those small tips about where to cut, where to put your blade. It's very important that your blade is 90 degrees with your bone. It needs to be a clean incision, know where to cut. Think about provisional restorations and their importance, their design. It's very important to understand this. Talk to your lab about this. You need to have a very good team with your technician. Think about final restorations and material selections. We didn't have time to go through this, but this is very, 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 you need to know, understand the difference in between materials. We have a class only for this in our courses, because I get to see that some people don't understand how their processes are being made, how the processes, what material take what time, what's important in which material. This is important that we know so we can understand our lab. Again, it's a team thing. And then maintenance and follow-up. Every 6 months, everything is unscrewed, clean, show to the patients. Those 2 pictures are important. Let them see what they're doing wrong. Seeing is powerful. And of course, check for torque, check for the screws if they need to be replaced, check for everything. This is a plan for lifetime. The patients will stick with you for the rest of their lives. Okay? And so that's it. Go and inscribe yourself in our course. It's much more detailed. And all the small tips and tricks will be there. There are a few that are very important. I'm sorry that we didn't get to go to Cambodia. We had to unschedule. I saw Dr. Paul asking the question there. I'm sorry, but there's for sure be another opportunity. And I leave you with my email. If you have some doubts, you can always contact me. I will try to answer you all. It's not been easy these last days. Only yesterday I spent hours responding to emails and to questions via Facebook, but I'll try to respond to you all as soon as I can. I will not promise you that I will be quick, but I will try to answer you all.
Yeah. I did thank you too. There's popping in a lot of more questions, and I think we have a little bit more work to do to answer all these questions. There was one question from Stamatios Matsinios from Greece, from beautiful Greece. Hello to Greece from this side. He was asking about the length of the rough surface of the osteo-integrated parts. How long is that part? How long is the implant or the bone level implant? So what's the length of osseointegration? And in the same, maybe you can answer to the final is from Gader Asur. He's asking whether the post-surgery. No, sorry, that's not the question we can answer now. Would a machine surface implant not be safer for a palatinal approach? It's asked by Cedric.
The what? I didn't understand. I didn't understand the last question.
The last question, a machine surface, and the first question about the length.
Okay. I don't have a clear. I tried hybrid implants with the machine part in the top and the rest not. I have not a clear idea if they work better or not, because my concern is that the part that is actually touching bone, they may be less efficient. So I don't have an answer for that. I've tried it, but honestly, I'm not sure. So that's the answer I have to give you. But in an idea, in a discussion, it makes sense. So if it's better or not, I'm not quite sure. I don't have sufficient material to tell you that, but it makes some sense. Regarding the other question, okay, so literature talks about 4 to 5 threads exposed. Those implants you saw were 16 millimeters. So in this scenario, it was more or less not even a third of the implant was exposed. But I have cases with 2/3 of the implant exposed and with no problem whatsoever. Remember that still we have more or less 5 to 6 millimeters of completely surrounded by bone implant in a very dense bone, aiming for the pyramid process. Remember that, very dense bone, and the rest is secured by this cortical, and very well secured by this cortical, and it's on the right positioning for the forces. That is something to do with forces that gives me much more confidence using these than the zygoma, where they are outside and the forces are against them and the leverage is way higher. This technique, not. The implants are inside, protected by that shell of buccal bone, and the forces, the leverage is way less. So for me, this makes all the sense in the world from a mechanical perspective, a biomechanical perspective.
Okay, thank you again, Joel.
Thank you.
Thank you for listening. I just take the chance to announce again our digital festival in beautiful Portugal at the end of September, where we're going to show, which we didn't discuss today, but Joel is involved in the developings of the new digital implant. Launching in end of September with all of you. So sign up for the digital festival, where also Joel Teles is showing his guitar skills with his and playing some music as well. So it's not only about digital dentistry, it's also about digital or electric guitars. So please see on our homepage the festival details. 25th to 26th in beautiful Cascais, close to Lisbon, with amazing speakers, some from the university in Zurich, others from Spain and Germany, and from Japan. We have speakers all around the world. Joel will be there. So we have an amazing time there at the end of September. The next webinar, which is important for you in these times, still on the 29th of April, we're going to have the webinar with Alex UNESCO with a different topic than the full arch restorations we just discussed with Joel. Here it's more about minimal invasive digital guided flapless implantology, main treatment options after the pandemic. I think this is a really big topic because it's all about being minimal invasive to not have too many open wounds in these times of Corona. And so from my side, I say thank you as well for listening. Thank you, Joel, again. Stay home.
Thank you.
And hopefully we can see us soon again in our
I hope so.
courses directly in reality. So
You look
tuned.
like RoboCop in that picture. You look like RoboCop in that picture, like this.
Yes. Okay. So bye.
See you. Thank you for listening, sir. Bye.